Hello. Good morning, respected Dean, Professor Khalid Al-Balushi, Professor Alka Ahuja, Assistant Dean for Academic Affairs, our guests, faculty, and students. Before we begin today's program, here is the safety reminder. Please take a moment to locate the nearest emergency exits in the hall. In case of an emergency, stay calm and proceed immediately to the assembly point outside the building and follow the instructions of the safety team. Today we have gathered for NU's College of Pharmacy Research Symposium of 2025. The theme this year is Collaboration and Innovation in Pharmaceutical Research for Sustainable Healthcare. It is organized by the College of Pharmacy's Graduate Studies Research and Innovation Committee under the patronage of the Professor Khalid Al-Balushi, Dean of the College of Pharmacy. Let's start the symposium with the national anthem. I would like to request you all to stand up for the national anthem. Sit down, please. Now we will have a recitation from the Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم الرحمن علم القرآن خلق الإنسان علمه البيان الشمس والقمر بحسبان والنجم والشجر يسجدان والسماء رفعها ووضع الميزان.
Now I would like to call Professor Khalid Al-Balushi, Dean of the College of Pharmacy, to give the welcome speech.
Bismillah ar-Rahman ar-Rahim. Honored speakers, distinguished guests, esteemed colleagues, Dean, Graduate Studies and Research at National University, dear students, Assalamu alaikum wa rahmatullahi wa barakatuh. It's my great pleasure today to welcome you all at the College of Pharmacy's annual Research Symposium, held this year under the theme Collaboration and Innovation in Pharmaceutical Research for Sustainable Healthcare. This symposium has become one of the most significant scientific events in our annual academic calendar, and I am truly delighted to see such a gathering of researchers, pharmacists, faculty members, students, and invited guests from across the profession. Today we are privileged to host esteemed clinical pharmacists, our colleagues here, as well as colleagues from some hospitals and health institutions across the country. Your presence enriches this event and highlights the importance of integrating academic research with real-world clinical practice. The theme of this year's symposium reflects a critical message. It reflects that sustainable healthcare cannot be achieved without strong interdisciplinary collaboration and the continuous pursuit of innovative solutions. The challenges facing global and national health systems, from chronic disease burdens to the rising complexity of therapies, demand that we work hand in hand across sectors, specialties, and settings. As pharmacists and pharmaceutical scientists here, our role is central. We are innovators in drug discovery and development, We are partners in optimizing therapeutic outcomes. We are leaders in promoting safe, effective, and sustainable use of medications or medicines. This research symposium provides a valuable platform for showcasing the outstanding research being conducted by our faculty, by our students here, as well as for learning from our distinguished external speakers whose clinical expertise in the profession bridges the gap between research, policy, and practice. Over the course of today's program, which you have it all, you will engage with research presentations, competitions, and discussions that highlight emerging trends in pharmaceutical sciences, clinical pharmacy, and health system research. I encourage all participants, I encourage our students also, especially the students here, to make the most of this opportunity, ask questions, connect with experts, and explore ideas that can evolve into impactful research projects. Our commitment as a College of Pharmacy is very clear: to foster an environment where scientific curiosity thrives, where collaboration is not merely encouraged but embedded in our academic culture, and where innovation is directed toward strengthening the sustainability and resilience of healthcare in Oman. Before we begin, I would like to extend also my sincere appreciation and thanks to the organizing committee, and to the Graduate Studies and Research Committee of the college, and also to the Deanship of Research, to our dedicated faculty, to our student volunteers, to our students who are attending, and also to our esteemed guests who have contributed their time and expertise to make this event happen and possible. Once again, I would like to welcome the College of Pharmacy's. I would like to welcome you all to the College of Pharmacy's Annual Research Symposium, and we look forward to a day filled with insightful discussions, knowledge sharing, and inspirations. Thank you all.
Thank you, Professor Khalid. Now I would like to call Professor Ramchandran KP, Dean of the Deanship of Graduate Studies and Research, to say a few words.
Distinguished invited speakers, Professor Khalid, members of research committee, faculty and students. Assalamu alaikum, very good morning to all of you. I'm highly honored to be here with our partners, researchers, innovators, faculty and students who are shaping the future of pharmaceutical research and sustainable health system. When you talk about sustainable health system, we look forward for a system that are resilient, accessible, and affordable. As Professor Khalid rightly mentioned, it is very important to have a platform for knowledge sharing, debating, discussion across the discipline, across the department, across the colleges, and across the institution, and across the border. Because the pharmaceutical research is undergoing a global transformation in the advent of the new emerging fields such as precision medicine, nanotechnology, biotechnology, artificial intelligence, machine learning, digital technology. These things have powerful impact on societal life. For example, genomic medicine is shifting highly towards targeted therapies. Artificial intelligence cut down R&D costs considerably and aids in the discovery of new drugs. And we use nowadays AI for decision making, which is in a few minutes we can find out the solution to very challenging problem. And you look at the manufacturing, there is a shift from green chemistry to more circular manufacturing systems. And pharmaceutical industries are known for the pollution and hazardous waste product. But the situation has been changed since 10 years or 12 years. We are moving more towards circular manufacturing, which is having less impact on environment as well as promoting sustainable system. Now, another important development that you can look at is the digital technology, application of digital technology. You see, nowadays it is possible to monitor from anywhere else at any time. Now, it is helping in predictive care and improves the patient outcome. And the nanotechnology is a big area, and obviously we look at very nanoscale instrumentation for all medical assistance. And therefore it is very important that this symposium has a significance, creating a platform to discuss the new emerging field challenges innovation. In this respect, the College of Pharmacy and Research Committee has taken efforts in bringing forward this symposium. As a university, NU is very much committed to promote excellence in research and efforts in improving and enhancing capability and capacity in observing these emerging trends. Therefore, I have no doubt to say that this symposium is very significant and play a vital role. So let me extend my sincere appreciation to the College of Pharmacy and the Research Committee and faculty for taking this initiative. And I am sure that with the distinguished speakers, this event will be quite very meaningful and fruitful, and it will be an exciting and interesting event. So once again, let me extend my appreciation to all faculty members who has taken effort in organizing this event, and let me extend all the best to the event. Thank you.
Thank you, Professor Ramchandran KP, for giving us the NU Research Outlook. Now I would like to call Professor Alka Ahuja, Assistant Dean for Academic Affairs and Chair of the Graduate Studies Research and Innovation Committee, to give us an overview of their research activities at the College of Pharmacy.
Assalamu alaikum and a very good morning to all of you. At the outset, I would like to thank our Dean, Professor Khalid Al-Balushi, for his constant support and motivation in this continuing research. And I extend my thanks to Professor KPR, Dean of Deanship and Graduate Studies and Research, for his support to the College of Pharmacy to enhance our research infrastructure and also research outcomes. So I would just like to give a brief overview of our research activities in the last academic year, 24-25, as we always do, that every year we talk about the research inputs and outputs, and also we talk about our research accomplishments in the last year. All of us know that we have our NU and College of Pharmacy vision and mission, and vision and mission both talk about improving the research along with the teaching and community endeavors. So now research is a very important component, and College of Pharmacy gives a lot of emphasis on building the research at the College of Pharmacy. Now we have already heard from the Dean of the Deanship of Graduate Studies and Research, and he has very beautifully highlighted the important areas and the emerging areas of research in the field of pharmaceutical research. So we all know that at the university level, we have NU Graduate Studies Research and Innovation Committee, and at the college level, we have two important committees which are actually responsible for research. One is the College of Pharmacy Ethics and Biosafety Committee, which takes care of all the approvals related to the research proposals or the research which is done at the college and also at the national level. And now we also have College of Pharmacy Graduate Studies Research and Innovation Committee, which actually oversees the other activities which are related to research. Now, what are the roles and responsibilities of this college level committee? We work closely with the National University Graduate Studies Research and Innovation Committee to ensure that all our goals are aligned to the National University vision and mission. We also monitor the research of our students and the faculty, and we are organizing the research development activities, and we analyze the feedback which we receive after these activities. And also the committee, they coordinate with the purchase office for research and chemical supplies for all the equipment related to research and the chemical supplies. And as I mentioned before, Ethics and Biosafety Committee, they evaluate the research proposals of the faculty and students to ensure that all ethical protocols, they are followed and there is no violation of the ethical standards. Now, at the same time, the committee also conducts research teaching nexus workshops, and they make sure that our research proposals, they are aligned with Oman Vision 2040 and Health Vision 2050. And at the same time, they are also compiling the data of the College of Pharmacy for dissemination in VC newsletter, NU Research newsletter, ABAC, and NU Research annual report. And they also coordinate training of staff and faculty in various research institutions for development in research. And at the same time, they also handle the consultancy project. At this point, I would like to give special thanks to Dr. Sumaya Al-Kindi, who is our research and study specialist, and she handles all these activities meticulously. And I would like to give a big round of applause for her dedication and commitment towards the research in the college. Now, I would just like to mention about the main two core areas of research. We have two core groups which are taking care of the research at the College of Pharmacy. And one area is for the drug discovery and formulation development, which is first area, which is the core area of research, which takes care of the computer-aided design, in silico molecular modeling, prediction of pharmacokinetic and biological properties. They are also involved with the design, synthesis, and pharmacological evaluation of heterocycling compounds of pharmaceutical interest. They also take care of phytochemical screening of the medicinal plants, and they also, as part of the group, also preclinical and clinical pharmacological studies are done. Then, at the same time, the formulation and evaluation of new drug delivery systems is handled by this group, and also they take care of development of the herbal formulations and the quality control studies of the pharmaceutical marketed formulations. We have recently introduced the second research core area group, which takes care of the medication safety, medication adherence, reconciliation, rational medicine use, pharmacoeconomics, and health outcomes research. And it has also now included interprofessional education, which is very, very important, and we should learn how to trust and respect other health professionals and work in collaboration with them. And this also includes pharmacy practice innovation and digital health, public health, epidemiology and health promotion, education research in pharmacy practice and healthcare. At this point, I'm not naming any particular faculty member because each and every one of us is involved in these areas of research. And I would just like to mention the grants which were received in the academic year 24-25. We received grants from Ministry of Higher Education, Research and Innovation. Then we also received grant from the National University, and also we have our own campus research fund. So we had total 5 funded projects in last 1 year, and we got the grant of 12,700 Omani Riyal. And this is about the campus research fund which supported this project, which involved investigation and association of ABO blood groups and oral health problems among Omani population. And the grant which was given at the campus level, the college level, was 1,400 Omani Riyals. Then this grant was given by the National University, which included inhibitory effects of natural plant products on cholinesterase activity, a rational approach for development of anti-Alzheimer drugs. And the grant was 4,800 Omani Riyal. And again, thanks to our National University for supporting the research. And we received another project funded by the National University, which was about the association between glycemic control and root caries lesions in Omani dental patients. And it is a retrospective and a cross-sectional study. And then we also received a project for the international collaboration, which was collaborated with another university which was outside the country, which was on development of intranasal drug delivery of spermidine-loaded liposome for the mitigation of neurodegenerative disorders. Again, thanks to Mohori, NU, and the College of Pharmacy for supporting research. Now, at the same time, Mohori also gave for the project for the undergraduate students, which was on the eco-friendly selenium silver nanoparticles, synthesis using Phyllanthus neruri extract, characterization, and the investigation of anti-cancer activity. Now, these are some facilities which we have at College of Pharmacy, and all these equipments they have been bought with the support of the NU, Mohori, as well as by some institutions outside that. When we have collaborations, then some equipments have also been supported from that. And we can see this. Also, the main thing is about our collaboration, which you can see we have collaboration with Royal Hospital, Khawla Hospital, and we're very thankful to our speakers for today who have come, who are actually in Khawla Hospital, and they have also been helping us in research for our undergraduate and postgraduate students. Then Armed Force Hospital, then Sultan Qaboos University Hospital, Diwan Clinic, then then Food Safety and Quality Center, which also supported our research, Oman Dental College, Nizwa University, and UTAS. Now, these are some faculty research activities. In last year, our faculty attended 18 conferences, and 1 patent was granted. 59 research publications and book chapters were contributed by the college. And then there were awards for the Best Research Presentation Award, recognition of Scopus Index, publication of corresponding authors. And I'm very proud to say that our faculty members, 2 of our faculty members were also listed in the Stanford list for the 2% of the research scientists. So now these are about the scholarly activities, about participation in the conferences and research meetings. You can see that the conferences which were attended by also included American Association for Cancer Research, International Conference on Recent Researches in Pharmacy, Agriculture, Engineering and Sciences, then 20th IC International Symposium, 11th Annual Research Forum, etc. So our faculty and students have been actively participating in these conferences and workshops. And you can see last year, as Professor KPR was just mentioning about this pharmaceutical waste management, which is again a very, very important area. Last year, our theme was on pharmaceutical waste management, which was organized in 2024. Now, you can see these are some pictures to support that how our faculty and students, they have been taking part in the presentations. And again, I would like to thank Dr. Sumaya, who has been collecting all these pictures and putting them all together. And these are some of our students' research activities who participated in 5th Annual Oman Pediatric Society International Conference, then NU Inventor Forum, then Oman International Pharmacy Conference, Dubai International Exhibition for Pharmaceutical Industries and Technology, DUFAT, where our students and our faculty have been participating and presenting their research. Now, these are again some pictures of our students participating also in Science Fair and Annual Research Forum and in Tech Startup Weekend. Even if our students, they participated in the innovative projects and they also scored, actually they got some awards and they scored. I can see some of them who participated are also smiling. So now, and we are really proud of them because they made us proud by winning awards in this Tech Starter Weekend. Now, this is just the summary of what I just presented. You can see the number of publications, the conferences attended, the proposals which were granted, and how many collaborations we have, and MOUs we signed with other collaborative research projects, institutions. Now, these are certain awards which I must mention because our student, you can see the picture, Hoda, she got prize, the first place in Tech Starters Weekend, which was organized from 17 to 19 October. Then second place was bagged by our MSc student Maria Khamis. And then also our student Maria and Bushra, they got second place in the 3rd Annual Science Fair. Now, thank you so much. And this achievement is actually the result of all our students and our faculty who worked hard for their research. And thank you so much.
Thank you, Professor Alka Ahuja, for sharing with us the College of Pharmacy's research achievements. Now I would like to invite Professor Khalid, Professor Alka, Professor Ramchandran, and Dr. Sumaya to the stage to release their research symposium proceedings. Thank you all. We would like to award our keynote speakers. I would like to call Dr. Lemia Ahmed Al-Shuhaimi, a clinical pharmacist at Khawla Hospital. Please come to the stage. Now I would like to call pharmacist Zainab Saeed Al-Hashimi, a senior specialized pharmacist in the plastic and reconstructive surgery and hand surgery departments at Khawla Hospital. Please come to the stage. Now I would like to call pharmacist Ahmed Talib Al-Zaabi, a senior specialized pharmacist from Sahar Hospital. And lastly, we would like to award one of our own dean, Professor Khalid Al-Balushi. Thank you all. Then I would like to invite Dr. Lemia Ahmed Al-Shuhaimi. She's a clinical pharmacist at Khawla Hospital. Dr. Lemia earned her PhD from Trinity College of Dublin, Ireland in 2025. Her doctoral research, titled Long-Term Use of Medications with Anticholinergic Activity in Older Adults with Intellectual Disability, the Prescribing Challenges and Impact on Health Outcomes, reflects her deep commitment to advancing safe and effective pharmacotherapy in vulnerable populations. She also holds a master's degree in service development in clinical pharmacy from Robert Gordon University in Aberdeen, UK, a bachelor's in pharmacy from Trinity College of Dublin, and a diploma from the Oman College of Health Sciences. Dr. Lemia's research interests include pharmacoepidemiology, anticholinergic burden, intellectual disability, and the health of older adults. Today, she will be presenting on anticholinergic burden, the clinical implications and health outcomes. Please join me in welcoming Dr. Lemia Ahmed Al-Shuhaimi to the stage.
Assalamu alaikum, everyone. Good morning, everyone. Thank you for the invite today. As I said, my name is Lemia Al-Shuhaimi. I'm clinical pharmacist in neurosurgery in Khawla Hospital, and I'm really honored to be here today and deliver a talk. I just came back from my PhD a few months ago. So today, because it's a research symposium, So as it's a research symposium, I thought I will give the talk as on my PhD journey. It's like an overview of what I did in the PhD. So as you know, the PhD is all about research, and I could describe the journey. It was a journey of resistance, resilience, and a ridiculous amount of coffee. It was a journey of resistance because I have been rejected more than 6 times to get a study leave. However, I was on unpaid leave, and I did it. It was a journey of resilience because I have lost my supervisor for more than a year, and it was in the third year of the PhD where most of the work should be done. But I managed to complete it within the time frame. And a ridiculous amount of coffee because you wouldn't be able to complete it without the coffee. So today, inshallah, I thought I will give you an overview about my educational journey, because I do believe this could be inspiring for some of you here. I gained my diploma in pharmacy from Oman Health Science College in 2012. The same year, I joined Khawla Hospital. After that, I did a bachelor degree in Trinity College Dublin in Ireland. It was 3 years. I got it as a scholarship from Ministry of Health. And directly after the bachelor, I did my master degree. It was MSc in Clinical Pharmacy Service Development. It was in Robert Gordon University in UK, and it was only 1-year program. I really enjoy it. During the master, I have secured a PhD funded scholarship, again from Trinity College, and I did it. It was 4 years program. So I just came back in April. During the PhD, which stands for Doctor of Philosophy, I was able to do 2 diplomas, one of them in statistics and the other one in research and entrepreneurship. So I thought we'll leave this slide as a PhD, which stands for a Doctor of Philosophy, because I do have, I know that as a pharmacist, we do not have a big background about the PhD, and why would we need to do the PhD as a pharmacist or a healthcare providers? So the PhD is considered as the academic degree you could attain. It will equip you to be an independent researcher, so you will be able to define the gaps or the knowledge needed, the problem, and to design the studies. It will help you to develop your critical thinking skills, because you will need to evaluate evidence and question assumption. It will help you to be a good communicator, because you have to publish all of the job you did, and you will need to present it in national and international conferences. And you wouldn't be able to complete it without the dedication and the problem solving over the years, so you will be able to develop the resilience and the persistence. So moving to the scientific part, my PhD was titled as the long-term use of medication with anticholinergic activity in older adults with intellectual disability, prescribing challenge and impact on health outcome. And the PhD was divided into 3 work package or stage, I could say. The first stage was the evidence gathering stage, and I did that by conducting a scoping review and a longitudinal study. After that, the second work package is about developing a theoretical components, and I did that by interviewing prescribers to know their perspectives about this type of medication and the adverse effect on using them on people with intellectual disability. And the final work package was about the data synthesis, and that was done by combining both of the gathered evidence-based and the developed theoretical components to help develop an intervention that would help the prescribers when prescribing this medication for people with intellectual disability. The PhD was designed based on a framework, a very famous one, known as the Medical Research Council Framework on Complex Intervention, or MRC framework. This framework provides researchers with guidance on developing, implementing, and evaluating a complex intervention. Why it's considered complex intervention in this case? Because we are dealing with people with intellectual disability. They are not a general population. So, and they have been excluded from the clinical trial because of the intellectual disability they are suffering from. So in my PhD, the framework is consisted of 4 main stages. The first one is the developmental of the intervention, then the feasibility, evaluation, and implementation. My PhD have provided all of the data, or most of the data needed to develop the intervention. However, I did not develop the intervention because that could be another PhD to be done after my PhD. So moving to intellectual disability, according to the WHO, is it defined as a significantly reduced ability to understand the new or complex information and to apply new skills. This results in a reduced ability to cope independently and usually begins before adulthood with lasting effect on developmental. And it's usually diagnosed by the IQ score or the intelligence quotient score. So those below 70, and they were classified into 4 stages. Those with mild, moderate, severe, and profound intellectual disability. However, according to the American Association on Intellectual and Developmental Research, they said that it is characterized by a reduced of both intellectual function and adaptive behavior. So it's not just measured by the IQ, but we have to measure the adaptive behavior, which about the skills for daily living and social interaction. And this one could be measured through 3 classifications. The first one is the conceptual skills, so it's the ability in learning, language literacy, and self-direction. Social skills, it's about the interpersonal abilities and problem solving. And the last one is the practical skills, so it's skills about the personal care and occupational tasks, so the daily and activities of daily living. What are the causes of intellectual disability? First part could be a genetic, and that's by chromosomal disorders. The most famous one is the Down syndrome, and there are Fragile X syndrome and other very rare syndromes. Heredity factors like phenylketonuria and galactosemia. Then there are some acquired factors. Congenital factors like neonatal hypothyroidism could lead to that. Toxoplasmosis, infection like syphilis could lead to intellectual disability. And developmental factors that could be divided into 3 classes. So prenatal, perinatal, and postnatal. Perinatal is before, during the pregnancy. If there is a malnutrition or infection could lead to that. And also uncontrolled diabetes during pregnancy could end up with intellectual disability. And perinatal, so the complication that's happening during giving the birth. And if there is a prolonged suffering of anoxia during the delivery and inadequate use of high forceps, could lead to intellectual disability. Postnatal, the different infections that could happen, especially meningitis, encephalitis, could lead to intellectual disability. Also, there are some environmental and sociocultural factors. So they found that countries who suffer from poverty have a high prevalence of intellectual disability, and that could be due to the malnutrition and the limited access to healthcare services. Also, they found there is a relationship with the family instability and the intellectual disability. So moving to the medication part, the title said as medication with anticholinergic activity. I didn't say anticholinergic agents because this one completely different. It's about any medication. We have a lot of medication that it's not classified as anticholinergic agent, but they do have anticholinergic activity. So when we define the anticholinergics, it's any type of medication that block anticholinergic receptors like acetylcholine, including both the muscarinic and nicotinic receptor. And they are usually classified based on their synthesis, so naturally occurring alkaloids like atropine and scopolamine, semi-synthetic like ipratropium, and synthetic like solifenacin. And what they are usually used for, they are widely used to manage various medical conditions. Anticholinergic agents is famously used to control symptoms of Parkinson's disease. However, we use a lot of medication to control severe insomnia, a lot of psychotic conditions like obsessive compulsive disorder, bipolar, motion sickness, overactive bladder, COPD, cardiovascular disease, neuropathic pain, muscle spasm, and irritable bowel syndrome. So they are widely used to control various medical conditions, and we'll go through them in more details. What possible adverse effect? It depends if the medicine would be able to cross the blood-brain barrier, so it will end up with a CNS adverse effect or central adverse effects, including cognitive decline, memory impairment, behavioral disturbance, insomnia, and anxiety. And there are peripheral adverse effects like urinary retention, tachycardia, dry mouth, constipation, blood vision, and glaucoma. In high doses, it might cause confusion, agitation, delirium, and seizures. So my topic, it's about anticholinergic burden. It's another new term. Anticholinergic burden, it's the cumulative effect on individual taking one or more medication with anticholinergic activity. So it's a cumulative effect. It's not from one medicine. And in general, older adults, they found that the long-term use or exposed to anticholinergic burden has been associated with adverse effects, including memory loss, increased dependency, increased mortality rate, chronic constipation, and higher risk of fall. And when we move to people with intellectual disability, they are exposed to a higher burden of anticholinergic compared to the general population. And that could be due to the high prevalence of psychiatric and neurological disease in people with intellectual disability. According to a cross-sectional study conducted on people with intellectual disability, they found that by being exposed to anticholinergic burden, it would be associated with constipation, daytime dozing. That means the patient will be drowsy all the day or sleepy all the day, higher dependence level on based on Barthel index, and the use of multiple laxatives. So the question that I was trying to answer with my PhD is, what are the adverse effects would be associated with the long-term exposure to anticholinergic among people with intellectual disability? I started with the evidence gathering stage by conducting a scoping review aimed to examine all of the research literature on adverse effects associated with the long-term exposure to anticholinergic among the studied population. And I end up with an empty review. That means there was no study that had studied the long-term exposure and possible adverse effect associated with the use of anticholinergic among people with intellectual disability. Both of the study protocol and the scoping review itself has been published. So then the second stage of the evidence gathering was the longitudinal cohort study. I have conducted a longitudinal within the intellectual disability supplement to the Irish longitudinal study on aging, or known as IDS-TILDA. It's the first nationally representative study that included older adults with intellectual disability comparable to the general population. And it's collecting data every 3 years, and they are referring to the data as waves of data. So this study was considered as the first nationally and internationally that were able to include people with intellectual disability and compare the result to the general population. For my own longitudinal study, I have included participants participated in wave 1, which was conducted in 2010, and the wave 4, which was conducted in 2020. So that's give us a period of 10 years between the two waves of data. I have only included those provided medication data at the 2 time points, so I can measure the anticholinergic exposure. And I end up with around 500 participants for the longitudinal analysis, and I have around more than 700 participants for a cross-sectional analysis where I have included all of the new participants in wave 4, because in wave 4 we end up with, so after 10 years of starting the study, people are getting older, so we needed a new participant aged 40 to 50. So there was a new recruitment in wave 4 just to cover the gap of the age. So moving to the methodology, I started with quantification of the anticholinergic burden. We could quantify the anticholinergic exposure with different scales or scores. For my own, I have used the anticholinergic cognitive burden scale. It's used to compute the total score of drugs to determine individual anticholinergic exposure. And in this scale, medication are assigned to scores based on their ability to, based on their negative effect on cognition. So medication with an ACB score of 0, that means they do not have an anticholinergic activity. Medication with ACB score of 1, it means they do have an anticholinergic activity or an affinity to muscarinic receptor, but with no known clinically cognitive effect. And medication assigned 2 to 3, that means they are established, they do have an established anticholinergic effect. and they are assigned 2 or 3 based on their ability to cross blood-brain barrier and cause delirium. Then the total ACB score was calculated for all of the participants, and based on their total ACB score, they were classified into those with no exposure, those with a mild anticholinergic exposure, that means their total ACB score is 1 to 4, and those with a high anticholinergic exposure, that means their total ACB score is 5 and above. And here is a snapshot from the list of medication included. So you can see number 1 is atenolol, which is a beta blocker used for cardiovascular disease. It does have an anticholinergic effect, and it has an ACB score of 1. You can see number 7 is amitriptyline, which is in use mainly for neuropathic pain. It has a high ACB score, which is 3. Also, you can see baclofen, which is a muscle relaxant. It has an ACB score of 1. And captopril at the end, it has an ACB score of 1. So moving to the result, there were around 30% of participants had no exposure. 70% of them had anticholinergic exposure. High exposure was on 30% and mild exposure around 40%. What we can see is that people remained with the same exposure at the 2 time points, so that we are talking about 10 years gap. So people were still being exposed to anticholinergic over the 10 years. And when we examine medication classes that contributed to this high exposure, we found that antipsychotic remained the top high class of medication contributed to this high exposure at the 2 time points, followed by anticholinergic, antiepileptic, and antidepressants. And when we examine the exact medication, we found that the top 4 medication remained the same at the 2 time points, having carbamazepine at the top, which is an antiepileptic with an ACB score of 2, then risperidone, olanzapine, and bipiridine. We found there was a reduction in the use of diazepam, which is benzodiazepines, chlorpromazine, haloperidol, and procyclidines. And that's because they are typical antipsychotics and have been replaced by a newer antipsychotics, which explain the reduction in the use. There was an increase in the use of escitalopram and quetiapine. When we measured the association with the adverse effect, so I have studied the adverse effect including falls, mental health conditions, so any mental health condition like hallucination, depression, and anxiety, and so on. We measured with dementia or Alzheimer's disease, Barthel Index, which a measure for the physical independency in daily activities, constipation, laxative use, and edontiolus. Edontiolus meaning losing their tooth, and they found that by suffering of a dry mouth because of the anticholinergic effect for a long period might increase the risk of losing the tooth. And what we found that there was a significant association between falls and the mental health condition. So by being exposed to anticholinergic burden in wave 1, it increases the risk to have a mental health condition and higher risk of falls after 10 years. And there was no association with the other outcomes. This study has been published recently, I think 2 months ago, in the Journal of Intellectual Disability Research. The second work stage is the qualitative study and to develop a theoretical component. So I have interviewed prescribers to know their perspective on prescribing and de-prescribing of medication with anticholinergic activity for people with intellectual disability. I examined their knowledge on the anticholinergic burden, possible adverse effect, tools used to quantify it, and identify the barrier and facilitator of de-prescribing, and how could the pharmacist be involved in the process of de-prescribing of this medication for people with intellectual disability. So the qualitative study could be the whole lecture, so I'm not going into more details, but I'm going through some of the key findings that I have found from the study in the next slides. The study protocol has been published also. So the finding and discussion. Although the use of the antipsychotic increased, there was a reduction in reporting both typical antipsychotic and anticholinergic agent. And that change could relate it to the shift in prescribing practice. The old prescribing practice was if I need to prescribe antipsychotic for a patient, I have to prescribe anticholinergic just to avoid extrapyramidal side effect. So people or prescribers have been shifted from this old practice because no longer it's usable in people with intellectual disability, even in the general population. Another study previously conducted in the IDS Tilda found that 1/3 of the participants were taking antipsychotic for behavior that challenge were prescribed anticholinergic also for the same reason. So people might be exposed to antipsychotic just to manage challenging behavior at a certain time and might not be get reviewed after a while. So the patient will continue on both the antipsychotic and anticholinergic for a long period of time just because no one has been reviewed the indication for the use of antipsychotics. Another study was found that there was no association between high anticholinergic exposure and risk of falls. However, in my study, we found that by being exposed to anticholinergic burden, it's increased the risk of falls after 10 years. So that's mean by being exposed to anticholinergic exposure for a longer period of time, that would increase the risk of adverse effect compared to the short period of time, the usage or the exposure to anticholinergic. The study highlights the necessity of reassessing prescribing practice, especially for the antipsychotic and the anticholinergic. The study raises a question about potential alternatives to medication with a high anticholinergic burden and whether these alternatives are effective, safer, and accessible for people with intellectual disability. The study have found that participants living in residential care setting and those with a mental health condition and those experiencing polypharmacy are more likely to have higher anticholinergic exposure. That's why we need a medication review is highly needed for this group of population. There was a limited awareness among prescribers about the tools used to quantify the exposure. Therefore, an educational program and CBD would be needed to raise an awareness. To conclude and take home message, so older adults with intellectual disability are exposed to a high anticholinergic burden and for a very long period of time. Antipsychotic and anticholinergic medication review is highly needed in this population to reduce avoidable anticholinergic effects and to enhance the quality of life in this population. The ACB exposure at wave 1 was associated with the higher risk of falls and reporting mental health condition after 10 years. Benzodiazepines were identified as the most difficult class to be deprescribed or fully deprescribed, with prescribing attributing this to the long-term occupation of receptors and the wishes of the carer. So I have participated in something called 3-minute thesis. I don't know if you do have this in here in the college now. Okay, so in this competition, you have to present your thesis, which was a work of 4 years, in 3 minutes, in a simple language for public and using 1 slide. And I managed to get 2 awards out of 3 in the competition in Trinity College, and the video has been used after that for educational purposes in the School of Pharmacy and School of Psychiatry in Ireland. And I thought the video will help to give you a summary of the whole lecture.
Did you know that individuals with intellectual disabilities are more sensitive to medication and that they are experiencing adverse effects at a higher rate compared to us? As a PhD student, I'm on a mission to enhance medication use for this group of population. And starting from this side of the slides, my studies are nested within the intellectual disability supplement to the Irish longitudinal study on aging, which is the first longitudinal study in the world that included people with intellectual disability. Despite being at a higher risk to experience adverse effects, people with intellectual disability are considered among the most medicated groups in society, and that they are exposed to excessive polypharmacy, which means being on 10 or more medications with a rate 6 times higher compared to the general population. and that they are highly exposed to certain types of medicine that have something known as anticholinergic adverse effects. These medications are widely used to control medical health conditions, including mental disease, neurological disease, gastric, allergy, and so on. The cumulative use of this medication is identified as anticholinergic burden, which measured through scales that quantify it based on the number and the type of medication taken by the patient. The higher anticholinergic burden, the higher adverse effects, including decline in cognitive function, decline in physical function, higher mortality rate, chronic constipation, and higher risk of falls. My studies examined data provided by around 500 participants participated at 2 time points with 10 years apart. And the study finds that 7 out of the 10 participants are exposed to anticholinergic, and 70% of them continue to be exposed for the 10 years. The study also finds that this long-term exposure was associated with the higher risk to develop mental health condition and higher risk of falls. The study also highlights the urgent need to review medication, specifically those used for psychiatric condition, as they were the most class of medication contributed to this high exposure. By reviewing the use of this medication, we could ensure safer and more effective medicine use. We could enhance the well-being and quality of life for individuals with intellectual disabilities, their families, and their carer. Thank you.
So thank you very much. Thank you for hearing. I hope it wasn't too long, and I hope it was clear enough. My advice, continue to achieve your goals. No one can stop you, and you could do whatever you want. Thank you very much. Any questions? No?
Thank you very much, Dr. Lamia, for this insightful presentation. You mentioned in your conclusion that, let's say one of the outcomes or the benefits or let's say recommendations from the study to find potential alternatives for the antipsychotics or anticholinergics. Knowing the complexity of diseases in the elderly people, what could be potential safer alternatives in such complex cases? That's basically the question.
Yeah, so it won't be an easy thing to find alternatives, and it's completely different in Oman when I compare it to Ireland, because we have a very limited medication or classes of medication in our healthcare services. So I would say it won't be an easy thing. It could be another PhD, because we would need to go through all of the alternatives available and to compare the anticholinergic adverse effect of this alternative to the previous one, and to make sure is it effective as the previous one. So there is a balance between the effectiveness and the safety. So the benefit ratio balance would take a place in that, and the clinical judgment will play a role in that. And if we are talking about, I didn't mention older adults. When I say older adults with intellectual disability, I am referring to those aged 40 and above, 40 years and above, because they found that people with intellectual disability aged 40 have similar comorbidities to those aged 60 and above in general population. So the number of medication and the comorbidities they are suffering, it started earlier in people with intellectual disability. So that's will play another, one of the factors to be considered, like how long we are expecting the people will live for, and is it worth it to stop these symptoms or not? Yes? Well, we haven't studied that in my PhD yet, so it's a recommendation for any further studies. But I think in incoming research, we will have to go through that in more details. وعليكم السلام ورحمة الله.
السلام عليكم. شكرا دكتور على for this nice talk. You mentioned intellectual disability is a wide range of disorders, صح?
Yes.
Now, did you look into this kind of thing, which is there a relationship with the different types of disorders, or just as general? I mean,
it's general, so we included all of those with intellectual disability. There was a point to study Down syndrome and Alzheimer's disease because they found a relationship between Down syndrome and having Alzheimer's disease. However, the number of people who reported Alzheimer's in my data was just 29 participants.
Okay.
That's why it wasn't like, it doesn't give a full data about that. We need a larger sample of data with Alzheimer's. But
So
in my study, I included all different types of intellectual disability included in IDS tilde.
okay, so you mentioned like you focused on, is that right? Is it you focused on two groups, Alzheimer and Down syndrome? لا مش هيك.
No, I didn't. Like,
You mentioned-
yeah, there was a point to study it further, and when we went back to the data, we found just 29 participants who have a Down syndrome and reported Alzheimer's disease. So it wasn't like a full data of a large number of data would need to investigate the relationship between us.
طيب, what about adherence? I mean, did you look into adherence? Definitely there's impact because these are dependent
Yeah.
on the carer, you know?
I could
So
go
is there-
further in that. So the medication information was collected. If the patient were able to put the medication himself, we will take that. However,
okay.
in most of these cases, the family would be involved and to collect the medication data because, you know, people with intellectual disability might not be able to mention all of the medication and how the doses they are taking. So the family barrier, or if they are in a residential care setting, so the carer will be able to provide all of the medication, and we are checking that also from the local pharmacies. They used to get the medication based
So
on that.
this is minimized, this kind of impact was minimized, this adherence problem, by following this, which is
So
carers and...
About the adherence, we are trusting the
trusting.
the carer and the family member. Okay, thank you very much.
Thank you, Dr. Lamia, for that insightful talk. Now I am pleased to invite pharmacist Zainab Saeed Al-Hashimi, a senior specialized pharmacist in the plastic and reconstructive surgery and hand surgery departments at Khawla Hospital. With over 19 years of clinical pharmacy experience, she has played a key leadership role in both outpatient and inpatient pharmacy services, including acting as a head of OPD and A&E pharmacy and a head of inpatient pharmacy. She currently serves as the focal point of the Research Ethics Committee and is a core member of the Antimicrobial Stewardship Committee. PH Zainab holds a Bachelor's of Pharmacy degree from Ajman University, a Master's degree in Pharmacotherapy and Medicines Management from University of Sunderland, and is currently pursuing her PhD at the University of Huddersfield in the UK. Her research focuses on antimicrobial stewardship, threshold logistic modeling of antibiotic resistance, and drug utilization. She has authored 7 peer-reviewed publications, including a book chapter contributed to an IV therapy handbook, and has delivered lectures at numerous national and international conferences. Today she will be presenting Knowledge to Action, Changing Prescribing Behaviors for a Sustainable Future. Please join me in welcoming her to the stage.
السلام عليكم، كيف الحال؟ It is my honor to be here and to present one of my research PhD. I will talk about prescribing survey. It is not moving. Okay. It is moving. Sorry. ما شغال. Next area. Okay, my topic will be prescriber knowledge, behavior, and attitude about antibiotic use and antibiotic resistance. And here the barcode, you can, sorry, it is moving a lot. Here is the barcode. You can scan it to see the articles. It is already published. And first, I want to ask you, and it is a brainstorm. And I will be, you have to be interactive on these sessions. So, do we have national action plan to combat antimicrobial resistance? Anybody know? Do we have a national action plan? Yes? How many said yes? Raise your hand. Definitely you have to know we have a national action plan. And that guideline or that document is collaboration with the National Ministry of Health and also the Ministry of وش اسمها هذه وزارة Agriculture. That was published 2016 and it is now mostly 11 years from them. And they are doing update. Second one is using antibiotic to stimulate growth on farm animals legal in Oman? No or yes? No, it is not legal to use the antibiotic to stimulate the growth. Do the bacteria spread from one person to another person? Anybody know? It is spreading or not? Definitely it is spreading. So I will talk on details about the survey we did it on the prescribing and also pharmacists and nurses. But today I will focus only on the result of a prescriber. So my outline is there. And the introduction, as we know, the antimicrobial resistance creates significant risk to the patient, healthcare system, and the world economy. There are around 1.14 million deaths per year directed from AMR, and an expected 4.7 by 2021 linked to AMR. By 2050, the AMR could cause up to 1.9 million, mean mostly 2 million deaths annually. In Oman, in 2019, their statistics said 177 deaths attributed directly to AMR and 700.4 deaths linked to the antimicrobial resistance. So the antibiotic use is sometimes inappropriate, and excessive use of antibiotic plays a very important role to developing the antimicrobial resistance. Studies have shown that physicians inappropriately prescribe the antibiotic due to the lack of guidance and also guidelines access and diagnostic tests and influenced by patient demand. Antimicrobial stewardship is driven by the prescriber knowledge of appropriate antibiotic use. Over prescriptions, antibiotic lead to severe infection, complication, and extend more length of stay on the hospital and increase mortality. So here the methodology, it is a cross-sectional study, and it is distributed among Ministry of Health prescriber, and it is used the European Center of Disease Prevention Control instrument. The questionnaire was distributed online, and the participants were given a brief overview about the study. Advice their participant was voluntary, and their response will be anonymous and kept strictly confidential. Statistical analysis, we use Rausoft sample size calculator, and then around 5,800 doctors was registered on that day, on that year, 2023, on Ministry of Health, and we calculate the sample size to be 361 prescriber. The data was analyzed on the SPSS. So here the result. Around the 49% was female. As we know, the mostly female, they are dominant on the answering and on this sector. And the age was 37 to 45 years, around 38% who respond to this survey. Majority was 65% from Muscat University, Muscat government. And sorry here, can I show it? Yes. The specialist who was answering was 36%, and senior the rule of specialist mean senior doctors or specialists or consultant. It was 46%. The hospital, it was 73% was participating or answering from the hospital institute, and the years here higher on 21%. It was having experience from 11 to 15 years. So I ask them this question. This is prescribing actual knowledge. We ask them, antibiotics are effective against viruses or not? True or false? They said mostly 85%, 95% they said false, which is correct. And it is high percentage. What that mean? High knowledge of doctors. When we ask them regarding the antibiotics are effective against cold, okay. It is not moving. So 85% from the respondents said false, which is correct answer. And when we ask them about the use of antibiotic make them became ineffective, 97% of the respondents from prescriber said the true, which is correct answer. So taking antibiotic associated with side effect, most of them they said yes, which is 97% agree on this statement. But I will not talk about a lot of measures here. So here, antibiotics spreading, antibiotic resisting bacteria can be spread from person to person. I ask you on the first slide. So doctors, they said only 80% of they agree and they answer correctly to that questions. Here it is moderate, it is moderate knowledge, and we need to increase it. They have to know about the spreading of bacteria resistance from person to person. About the use of antibiotic to stimulate growth in farm animals is legal in Oman. Only, unfortunately, 34% of doctors, they agree on that or they correctly answer about the questions, which need to highlight these issues and increase the awareness on this topic. I ask them about the perceived knowledge and if they know what antibiotic is. Most of the prescriber, as we can see, 87% agree on this statement. Here the abbreviation: strongly agree, agree, disagree, strongly disagree, not available, undecided, and I don't understand the question. I don't understand the questions. So most of the doctors, they have high and they agree on the perceived knowledge, okay. And when we ask them if they have opportunity to access the guideline, 73% they say yes and they agree on that, but the rest they don't have easy access to guidelines. When we ask them regarding the easy access to the material they need to give the advice about burden antibiotic resistance, only 66% of doctors, they say they have this easy access. So here we have a problem. We have to increase the material and make it easy access to doctor, to give the public and to improve the knowledge about the antibiotic resistance and antibiotic use. For giving advice, when we ask them, only 77% they strongly agree and agree they are providing advice to the burden antibiotic use and to the individual, I mean to the patients. What about the motivation? The motivation to initiate the antibiotic prescription. As we can see here, the doctors, almost 84%, they say there is a connection between their prescribing the antibiotic and the spreading antibiotic resistance bacteria. That is good. I mean, they are addressing this as a problem, but we need to make them as 90% at least to know there is a connection between their prescription and so on. When we ask them, I am confident to making antibiotic prescription decision, only 81% they are confident. And regarding the guidelines, only almost 80% as well, they agree on this. So they have to be confident. They have to be confident on the guidelines they have it on the hospital as well. What about the key rule for helping control antibiotic resistance? Only mostly 70% they agree on this statement. Regarding the support not to prescribe antibiotic, when they are not necessarily, only they answer 96%, which is very good percentage. So second one, One Health. Do anyone know what is One Health? We are here on the planet not alone. We have the environment, we have the animal sector as well. So the environmental factors such as wastewater can contribute the resistance bacteria. And there is a study on Oman, done by microbiologists. They test the wastewater and they found there is a lot of resistance and cholesterol resistance, a lot of bacteria resistance to the antibiotic. And those mean it will alert ourselves from where it is coming, this resistance. Mean we are using the antibiotic and it is going to the wastewater. Second one, the excessive amount of antibiotic on livestock and food. There is only 65% of doctors, they agree on this, which is need to be highlighted. They have to know it is not correct to use the antibiotic on stimulation food. Next step is opportunity to provide antibiotic or resource related to burden use of antibiotics. When we ask them the frequency, it is here abbreviation, it is more than every day, more than once every week, not available, or yani it is never, rare, every day, every week, no, not applicable, and I don't remember. So we ask them, how many often you prescribe antibiotic during the last week? 43% they said every week, more than once every week, and more than once every day. And when we ask them, do you give any resource to the leaflets, pamphlet, to the patient to avoid the antibiotic use and resistance? Only 45% they said never, which is need to be highlighted. They have to educate patient, because sometimes the patient demand for antibiotic taken. Regarding the advice related burden antibiotic use and management of infection, 23 patients and 23% and 15% they said never and rare to give the patient advice, which need to be highlighted. We have to educate the public, the patients, to not use antibiotic when it is not needed. Regarding the behavior, which is very, very important. The behaviors, prescriber behavior is very important to reduce the antibiotics. So we have to understand the behavior of prescriber. When we ask them regarding how often you are preferred not to be prescribed the antibiotic, but were not able, only 40 or 50% of doctors, they said yes, they agree on that. When we ask them if they are fear of patient deterioration or fear of complication lead you to prescribe the antibiotic, around 24% they said rare to do this. So that is good, but we need to increase them. They have to not let the fear of complication or fear of deterioration of patient, if there is no symptoms or no clear sign and symptom, to start the antibiotics. So we need to address these problems. Okay. Second thing, the antibiotic prescribing behavior. Antibiotics, they are prescribing to maintain the relationship with the patient. When we ask them, they said 62% they are not prescribing the antibiotics for the patient on these cases, so that is good. Regarding the uncertainty about the diagnosis of the infection, also the good things, more than 60% of doctors, they are not prescribing the antibiotic on these cases. This questions was made of if the prescriber receiving any information about avoiding unnecessarily prescribing of antibiotic. 70% of doctors said yes, they have been received information about that. Among this 70%, when we ask them, did this information change your view and on the avoiding unnecessarily prescribing? Only 91% they say yes. Among this 91%, did this prescribing did this information cause change on your practice of prescribing antibiotics? Only 93% they said yes. At least it is a high number of doctors, they are receiving information and about the antibiotic stopping, and they are changing their view and they changing their practice. This is the topic of the prescriber. They want more to receive about information. The highlight is 66% They want to know about the resistance of antibiotics and how to use antibiotics. And also some of them, they mention medical condition for which antibiotic are used, and so on. It is good 38%, they want to know the link between human and animals and environment. Sorry, here it is not appear. It is environment. Say at least we need to share with them this topic, this information, to let them increase their understanding and changing their prescribing behavior. So in discussions, this result, it was revealed that prescribers have almost same high level of knowledge comparable to the other study done on the same ECDC instrument tools, and regarding the effectiveness of the antibiotic against virus and the unnecessary use of antibiotic and the associated side effect, while they are demonstrating moderate level on the knowledge of the effectiveness of antibiotic against cold infection, and the risk of antibiotic resistance infection increase with every person treated with antibiotic. The study revealed that 70% of a prescriber know about National Action Plan, which is moderate knowledge. We need to share the guide, the booklet, and explain to them, because it is containing a lot of about information to do a research, what to looking for, and surveillance, and a lot of things on both sectors. So the conclusion, the finding of this study should be used to raise awareness about the antibiotic use and antibiotic resistance. Healthcare professionals need to be used diagnosis of a skill and change their prescribing behavior, and to avoid unnecessarily prescribing of antibiotic and the use of national guideline, which is very, very important. We already have launched the National Antimicrobial Guideline in 2024. Ahmed, 24 ولا 25? Early 25. January, أيوة, January 2025, and it is already on the website of Ministry of Health for you to see, to distribute it among the health institute. So our finding can be informed the antimicrobial stewardship team to implement an education program on the hospital to increase the knowledge of the all new prescriber about the antibiotic use and antibiotic resistance, and the AMS should be engaged the prescriber in all activity to help to reduce the AMR. So what is the next? Anybody can tell me what is your opinion on this? We did the survey. We found there is low knowledge on some topics, and we need to do something. What, in your opinion, we have to do? Awareness. Okay. What else? Decision maker.
We can work on the weakness area. On your survey, there are some areas where more than 70% of prescriber has some weakness in the knowledge or something. So if we work on that area, that will be the good thing for sorting that problem and raise the awareness.
Yeah, correct. So we have to raise the awareness of the key finding. We have to strengthen the understanding of AMS principle and also antimicrobial stewardship principle, and share it with the doctors on the institute and so on. We have to bridge the gap between the knowledge and the prescribing practice. Then we have to promote sustainability, rational antibiotic use on our daily clinics. So when we are providing the doctor guidelines, raising the awareness, increase the knowledge about AMR, let them contribute on the AMS team that will we can get from them the daily practice changing on the prescription. They will think twice before the prescription they prescribe the antibiotic for the patient. And also they will when the patients usually asking the or demanding for the antibiotic, they will let them to stop and give them advice and so on. So we have to bridge the knowledge practice gap. Although prescribers show good awareness on this survey and positive attitude toward the stewardship, but sometimes you can see empirical antibiotic use remaining high, and especially the broad antibiotics. So we need to tell them, don't start empirical antibiotics. We have to, or they have to start it according to the sign and symptoms of the patients. And each patient should be treated individual. Not all the patient coming with a trauma, we have to give them antibiotic. Maybe it is different from each case. We have to apply de-escalation, and it is not used on daily basis. What is de-escalation? It is a step down from the higher antibiotic to the what is called nowest antibiotics, which according sometimes to the result to the microbiology result. We have to adhere to the guidelines. Sometimes then the Ministry of Health, they have the guidelines, which is I talk about it, but each institute, they have also local guidelines. We have on Khawla Hospital our local and empirical guidelines. Why? We don't want as some certain antibiotic to be on the first line of empirical. And we show it, we already launched on our hospital. What about you, Ahmed, on Suhar? You have your own as well, and also they have national guidelines. So each institute is depend on what, why we did this guideline on our local hospital. Yeah. Yeah, that is coming what? Antibiogram. It is need for each hospital to develop and prepare the antibiogram that will let the decision maker to know what to use, to know the pattern of resistance on their hospital. It is different from each hospital to different hospital. We have limited use of micro, and this is what I said. The feedback system for prescribing performance are weak. We are talking to the doctor every prescription coming, it is not correct, or it is duration is not okay. So we need to work on this feedback. It should be case study. I think this case study, we have to discuss this, some of cases on the morning meeting with the doctor and bring for them the solution for their enhancing their practice. So this is like a feedback. So as the end, we can say the awareness is not enough. We have to do the action. So we have barriers to optimize the prescribing. We have diagnostic uncertainty. We have high workload and time pressure, lack of timely microbiology result, patient expectation for antibiotic, fear of a clinical deterioration, and limited of audit and feedback mechanism. This is all it is a barrier. It is a factor can be affect you on the hospital. So we have to resolve all these problems. So we have to do continuous professional education. For me, after the survey, I did 12 lecture for doctors and explain to them their result. Also give them more information about the AMS, the AMR and AMS team and what we are doing, what we are going to do. And they was very collaborative on this thing. A strong instituting support for our AMS program. We have AMS program mostly on maybe 2-3 hospital. We have Ahmed عندك فكرة? Mainly not all the hospital they have AMS team. So AMS team should be consist of from microbiologist, infectious disease, pharmacist, and also can be يعني add nurse, and it should be يعني also one from administration to give you a power to implement whatever you want to do on the stewardship and do in the hospital. Regular feedback on prescribing practice. We are doing regular prescribing by giving feedback. Each case, we are calling the doctors and explaining why to start this antibiotic, why to shift the patient to another, and giving their the advice every day. On our Khawla hospital, to be honest, our daily work is antibiotics. The prescription, it is first containing antibiotics. The antibiotic should be stopped or not. This is our daily thinking. And we are treating each patient different than others. We have to look for everything for the patient, then to decide the antibiotic choice. Effective multidisciplinary collaboration, as I said, ID, pharmacist, and microbiologist. Clear and update local antibiotic guidelines. As I said, we have to had guidelines on our institute. Access to antibiogram and decision support tools. We already have antibiogram. I think Sohar, they publish there. And inshallah, we will publish our Khawla Hospital antibiogram soon. And that help us to get the resistance. What is your first antibiotic resistance usually? Yeah, and earliest was Acinetobacter baumannii.
Yes,
correct?
yes.
Yeah.
So,
Mainly now, gram-negative bacteria is dominant on our hospital.
see,
not
Zainab,
Staph aureus.
earlier, because we had some different problems, that before we start our AMC, but that will be in my lecture, so that will be easy.
To explain it. Okay.
Yes.
It is okay. I want to to share it with them, because some of hospital they have like Royal Hospital they have CRE. We have carbapenem resistant Acinetobacter baumannii. Then degrees, it is coming CRE, Klebsiella pneumonia mostly. And also ASPL E. coli, now it is raising as well. So each year or 2-3 years, it is the pattern of resistance, it is changing. So we have to translate the knowledge to action. So we have to do a strategy for daily practice use, like choose the empirical therapy wisely based on local data. We have to review the antibiotic at 48 hours, 72 hours. It is like they say that antibiotic time out, so we can change based on the culture or based on the patient situation. If he is improving, we can de-escalate or shift it to from IV to oral. De-escalate, I already talk about it. Avoid prolonged broad spectrum use. When you are using broad spectrum use antibiotics, try after 48 hours or 72 hours to change it to another narrowest antibiotic. Document the indication, duration, and review the date on the chart. You have to document when I will see the patient again, and also the indication and duration. It is very, very important, the duration. Some cases need like 5 days, some of them 7 days, some of them even up to 8 months. So you have to document everything, then you will discuss us later on and see it is like a case real scenario. Engage the AMS team to support when it is needed. So takeaway message, good knowledge does not always translate to good prescribing. The barrier must be addressed at both individual and institutional level. Education plus support plus feedback, it is give you better antibiotic decision. Prescriber play pivotal role to combating AMR. A small change in daily practice is a big impact to resistance trend. So thank you for the lectures, listening to me, and if they have any questions, tell me.
Thank you, Pharmacist Zainab, for an excellent presentation. It's just a query, it's not a question. Basically, you mentioned about avoiding prolonged antibiotic therapy. So I could not understand the point which you mentioned, that when you're continuing it, then you step down to the lower category of antibiotics. This is what you said?
Yes.
Yeah.
Usually, I mean the empirical therapy.
Yeah.
Because patient you have now, you don't have any culture based on this. So we will give him empirical therapy, broad antibiotics which can cover gram-negative, gram-positive, and anaerobic covering. So in this case, for example, I will give him tazocine, augmentin, or meropenem. Okay. Later on, after 48 hours, I will assess the patient. There is culture sent to the micro. After that, I will, if the result is appear, I will change it to narrowest the selection to the according to the result from microbiology.
But this is actually contradicting with that. Sometimes we say that certain microbes, they will only be acting, only certain antibiotics will be active against certain microbes.
Yes.
So now when you are stepping down after 48 hours or maybe after 72 hours, so later on, will it not lead to any resistance or something? Will it not be an issue? Because after some time the patient might get the same infection.
Yeah, this is actually we don't say the meropenem when we are giving for 3 days, then it will shift it to, for example, ciprofloxacillin or shorter according to the result, it will cause resistance.
No, not resistance. The person might get the infection after some time, temporarily they are suppressed, but after some time the person might show the similar type of infection. So
no, because, but we have to treat him according to the culture. So definitely we'll give him the narrowest antibiotic according to the microbiology results. We will not step down.
So do you get proper results after giving antibiotic for a few days and then doing against the culture and then shifting?
Yes.
So that's what you do.
First thing, when you are receiving patients, even having sepsis, okay, we collect blood culture. Then we'll start the empirical antibiotic. After 48 hours or 72 hours, the preliminary result will appear. We can step down or add more. It is depend.
Okay.
If it is gram-negative, for example, you are starting meropenem, but MRSA came. You have to shift it to another. You can give vancomycin and stop meropenem. But if there is on the culture still not released, after 72 hours, continue with meropenem. And you can add also vancomycin to cover if the patient is sick. Okay? But after 4 days, definitely the culture will appear. It will show you which bacteria is there and treat the patient according to that results.
Okay, just one small question. Like normally, some prescribers, some doctors, they will say that no, okay, it's a viral infection. You don't need antibiotics, but there are chances of some secondary infection happening. So I will give antibiotics. Now, it is actually irrational, but then it is the discretion of the physician. So sometimes when we say that it is irrational prescribing or something, but it is also the discretion of the pharmacist or the physician. So how do you justify, or do you see such cases in the hospital?
On the hospital, we are not seeing that much, but on local health center, I think we are seeing these things.
Also in private
Private
sector, yeah.
sector, yeah. They have to judge by the test. They have microbiology tests, and they have to send to swab, culture, whatever blood. To also they have procalcitonin to judge if it is this infection or not infection, to start the antibiotic or not.
That's the ideal condition, but
yeah, but sometimes you have to convince them. Doctor, they have to convince the patient not to start antibiotic unless something clear and clear is infection.
Okay, thank you, thank you.
Comment to Dr. Alka. See, antibiotic journey is not an easy way. It's doctor way, public way, pharmacist way. So you should raise awareness for everybody, and it's not only for us here in our countries, even outside. Still there is some gaps. Still there is something to raise awareness. As you said, that's common cold or virus infection, no need for antibiotic. But still there is some way, some exception, there are some complications. But why should we treat complication before it happens? But some patients, they are used to do it. They want to, doctor, I want this antibiotic, you should give me this antibiotic. But still, it is wrong practice. And we have to correct it, but it's not an easy way to correct it once. You need some days, raise awareness of the prescriber, awareness of the pharmacist, awareness of the public, awareness of the agriculture as well. So it is not only one way, it is different ways.
So it's awareness not only to the prescribers, but also to the public, because people are also doing self-medication.
Yeah.
You know, many private pharmacies, they are still dispensing that, you know. So self-medication for antibiotics is very common, you know.
That's correct. That is one of component we have to raise it, to do awareness on the public. And we did almost 2-3 sessions, and inshallah by next year we are aiming to increase this public awareness and also increase the awareness among health centers, still on the Ministry of Health. But my thinking to expand it to the local private hospital and health institute, private health institute.
Thank you.
Thank you. Thank you, shukran.
Thank you, Pharmacist Zainab. Now I would like to invite Pharmacist Ahmed Talib al-Za'abi, a senior specialized pharmacist at Sahar Hospital. He is a committed and proactive clinical pharmacist who provides care in both adult and pediatric ICU and served as the coordinator of the antimicrobial stewardship program at Sahar Hospital. Throughout his career, he has helped in multiple key roles, including superintendent, section head, department head, private pharmacy registration inspector, and a controlled medications pharmacist and a clinical pharmacist in various wards. He also worked in outpatient pharmacy, serving as the pharmacist in charge of stores and managing narcotic medications. Mr. Ahmed began his service within the Ministry of Health in the year 2000 and has worked in both Sahar Hospital and Rustaq Hospital. He holds a Master's of Pharmacy degree and a postgraduate diploma in clinical pharmacy from the University of Strathclyde in the UK, and is also a graduate of the Oman Assistant Pharmacy Institute. He has contributed to many scientific research projects and has participated in various professional events across the country. Today he will speak on optimization of the rational use of antimicrobials from Sahar Hospital's perspective in antimicrobial stewardship. Please join me in welcoming pharmacist Ahmed Talib al-Zaabi into the stage.
Assalamu alaikum. Thank you for the organized committee, and I'm happy to be here and join you with sharing our experience in Sahar Hospital regarding the antibiotic. Thank you for Dr. Zainab. She gave me a lot of brief information before I start my presentation. My presentation going to the practice. Earlier presentation was about academic and PhD, but my presentation will be about the practice and our Sahar Hospital perspective. My objective in this presentation to introduce the antimicrobial stewardship in Sahar Hospital, how did it started and where we are now, and what we achieved, what were our challenge during that years from we have already started, and we'll highlight our challenge. Sorry. I will highlight our challenge during these years to achieve what we are already in this year. So we'll start with introductions and pharmacy and antimicrobial stewardship, then go what happened during the COVID-19, because we have started our stewardship just before the COVID-19. That's why we have some problem during the COVID-19. Then go to the challenge, then achievement and numbers, because when we want to count our achievement, we should have some numbers, because numbers give a clear image about our achievement. Why do we need stewardship? We need stewardship that's to control the antimicrobial use. As Dr. Zainab said, antibiotic used in different ways. And there's different use for antibiotic, and even the doctor needs some awareness about the antibiotic use. And the main problem is that antimicrobial discovery pipe is dry. No more antibiotic was discovered in the last 50 years. You can see here, during the last 50 years, there are only 1 or 2 antimicrobial was discovered. The red one is gram negative, the blue one is gram positive. So no more antibiotic we have in our market. What we have is what we have. Another way, the resistance is increasing. So we don't have a new antibiotic, but we have resistant to antibiotics. So that's why we should work what we have already. So we cannot use, because we don't have new medications. So once we have resistant, so the patient maybe die from common cold or from simple infections. So we should control our antibiotic, we should reserve it, we should use it rationally. The main definitions for stewardship is the control and use of antibiotic for the correct dose, correct patient, correct infections, correct patients. We shouldn't use it for anybody. We shouldn't use it by just patient have some infections, or will have infection, so we'll give him prophylaxis. No. It is depend on the correct use of the medication. As Dr. Alka was asking, that patient will come to the hospital and may have some infection. We'll give him empirical. Yes. It is depend. It is not depend. I will not give empirical for any infections. No. Because I should decide, is this patient was in the hospital or he came from home? Because if he came from home, that means the infection is community acquired. It's not hospital acquired. That gives me some ideas which antibiotic should I start. Because if he was in the hospital, so he mostly have some hospital acquired infections. But if the patient came from home and he was never in the hospital, that means they give me idea that the infections is from community. So I will think about the antibiotic which cover the infections who came from communities, not from the hospitals. For example, if the patient came from hospital, he was in the hospital 2 weeks ago, so mostly I will think he may has Pseudomonas or may has MRSA. But if he came from community, so that means something else. It's not included. So I will not give something to cover the Pseudomonas and MRSA. There is some strategic. It is not something need to give any antibiotic. No, we will not give any antibiotic. We decide according to the patient, to the condition, to the infections. That's why we have stewardship. which control that process in general. So in Sohar Hospital, our stewardship started at the end of 2018. You can see 2019. And it include infectious disease doctors, pediatric and adult. We have clinical pharmacists, and we have some staff which is to help us from the pharmacy, because the main component of stewardship is pharmacist, because he's the guy who controls the stewardship. Yes, there's infectious disease, but the pharmacist, he's the guy who controlling the stewardship. The stewardship started from the pharmacist, then go to the infectious disease. So the main component, as I said, is pharmacist. So we work in the beginning, in the 2019, we should increase the awareness of the doctors, the department, the people, because the people in the hospital doesn't know what's stewardship. So there's some new service coming on, and they should know about the service, what those people going to do in our hospitals. Because some doctors or some staff in the hospital, they said what they want to do with us. We know how to use antibiotic. It's an easy work. We do it every day. But when we start with them, yes, we have some conflict with them. But at the end, they know we are doing our job. We are not a police. They thought we are a police. Yes, really. When they saw us and with them in their department, the police is coming up. So be careful. Because we know we are checking everything. We are checking everything. So our hospitals, before we start our stewardship, so we're thinking, how can we start? There's some other different strategy of stewardship. Our stewardship starting on pre-authorizations. This is one of strategies of pre-authorization. There's a form. So we divide our medication to 3 groups of medications: green, yellow, and red. It's like now what's in the WHO, it said this is access, aware, and something. But we do it in 2019. So the green group, that's anybody can prescribe it. The medication with first-line medications, augmentin and others, that everybody can prescribe it. Then we have yellow groups, which can be prescribed as empiric, but should be revised after 3 days when that culture comes on. And we have the red group, it's only prescribed by the ID or approval from the ID, and nobody can prescribe it. This is restricted medications. That's why they have some talk about Sohar Hospital. They said Sohar Hospital doesn't like meropenem. We like it, but we restrict it. We don't use anybody to use it. We don't let anybody to use it, because we thought meropenem, colistin, tigacycline, linezolid, it's not a medication which can be used for empirical. It's restricted antibiotic. It should be reserved for last line of treatment. But for other hospitals, maybe they use it as their antibiogram. But in Sohar Hospital, no. We keep it for ID to decide to prescribe it or not. That's why our consumption in these medications and our resistance reduced dramatically, because we restrict some medications and keep it for our strong infections. So if you go through our rule in Sohar hospitals, so that's the prescription prescribed by the prescriber. The pharmacist check the prescriptions. If there is something wrong or something need to be interfered or need some intervention for the pharmacist, so the pharmacist will document this and communicate with the ID and discuss the case. Is it possible or not possible to prescribe such medication for such indication, for such patient, and such dose, for such duration? Then when we decide, we'll contact the primary care, the primary team, and we'll discuss that matter with them. This medication is not the medication of choice for such patients. So please, if you don't mind, could you mind to change the medication? And this is the option do you have. Some of them accept, some of them no. In the beginning, we were flexible a little bit, because we need to not be like a police, but we need to improve and have some trust with them. With time, we got this trust, but it's take long distance for us to have this trust. Because we need to know where are we in Sohar Hospital. That's why we have our first research. That's why prospective analysis. We check our isolate in our lab to check how much and what is the pattern of resistance in Sohar Hospital. So by this research, we found a lot of informations. What do we have in Sohar Hospital? Where's our pattern of resistance? And where to start our job, our work in Sohar Hospital to improve our service as antibiotic stewardship. So that have more than 15 samples from the lab. That's all the isolate from microbiological lab was analyzed, and we found a lot of information. So the predominant bacteria was gram-negative. It's more than approximately 70% were gram-negative in our hospital. And most of them was E. coli and Pseudomonas. And it was virtually no resistant for Klebsiella and tegacycline at that time. And we have a lot of cones, which is mostly it is gram-positive, but mostly it is not pathogenic, so shouldn't be treated. And a lot of have approximately 50% Staphylococcus MRSA and cones. So that gives us an idea what's our situations, where to start. So by this information, we start our job. This was in 2019 and 18 and 19. Then we have another ideas. Is it the knowledge and attitude of the public in our country same as other people outside our country? So we contribute another research which was with 11 countries, Arab countries in the Middle East. So we found the same problem, it's with us and even with them, because some people, as maybe Dr. Zainab said, there are some people that don't care about antibiotic, they don't know how to prescribe antibiotic, they don't know what the use of antibiotic. So we have another study which gives us an ideas that in this study we have approximately 3,000 participants, and there are approximately 60% of them, approximately 60% of them have wrong answer about should stop antibiotic when they feel better, because most of the people, when they can take antibiotic, once they get better, they stop antibiotic. But actually, they shouldn't stop. They should complete the course. But most people will stop when they feel better. So that was not only in Oman, even other countries, the same problems. And that's more than 70% of the people, they saw the antibiotic can treat cold and flu. But it's not. Same ideas with Dr. Zainab about the doctor said, there's some 11 or 10% with doctor said they can't treat. So the same idea, not only with the doctor, even in the public. They said it can treat some others problems. And nearly half of them, over the person indicate that uncertain of how antibiotic resistant affect the body, because they don't think that antibiotic can have a resistant. It is a medication, can be taken anytime by anybody, even as Dr. Alka said, can be brought from private pharmacy anytime. But actually it's not. It's not unlike another medication. It's a medication with a strong effect and can get resistant to other antibiotic and can be transferred from person to person, not only from the same person. Then in COVID-19, that was a strong area for us to work as stewardship, because at that time nobody knows how to treat the infection. So that was a difficult area for us, a difficult time for the stewardship team to work in that area, because we should control everything and nobody knows how to do what medication should be given. But at that time the team was strong and they work hardly to get everything stabilized and stable and get better for the patients. The main problem with that areas was mucormycosis, because in Sohar Hospital was the biggest number of mucor, and Sultanate was in Sohar, more than 13 patients. So the team was working 24 hours, and they should prepare the medications and should have a guideline every weeks. Because our national guideline was every month in Oman. But in Sohar, we were making a guideline every week, because the information was updated globally. And the main problem that was no medications. So we should prepare our guideline as per the available medications. So nobody know how to treat, but we should use what we have in our hospital. And we were waiting for the national guideline. It's only approved after 1 month maybe from the COVID-19. But in Sohar Hospital, we had every week or every 2 weeks, we have a new guideline as per what do we have in our hospital as per the national guidelines. So we are following the national guidelines to treat the patient, what do we have in our hospital. And the main thing that's preparing of medication for the patient of Mucor. And after that, we have published what do we have in Sohar hospitals was published, and we were a multidisciplinary team. As we said, that's health always multidisciplinary team. You cannot work alone. So not only the pharmacists, we have big teams. We work together. We have a group. We are discussing everything every hours or every day. You can say it for the patient. When there is a new patient, we have all the informations for everybody in our team, which we are working in that COVID-19. The challenge, because in our guideline and our stewardship, we have two challenges: the consumptions and the resistant. So you cannot work in one areas. Stewardship is not controlling the consumptions. It's controlling everything related to the antibiotic. So the main areas is resistant and consumptions. They are working together parallel in the same way. So we were checking the trend of MDR in Sohar Hospital between 2018 and 2019. You can see the ACBL was high in 2019 in comparison to 2018. The same thing for CRE, it's mostly similar, so it wasn't that problem for us. Even for other antibiotics, the resistance for antibiotics, you can see the Klebsiella pneumonia susceptibility for some medication is different from 2018 and 2019. We need all this information because that helps us how can we improve our practice. Because if we don't have this information, so we cannot work because we don't have the baseline or the fundamental information to work on and improve our practice. Then the consumptions, we find that after 1 year of controlling our resistant and consumptions of some medications, you can see here for linezolid, we have spent more than 1,000 in 2017 and 1,500 in 2018, but see it is 600 in 2018. So it was massive misuse of medications. This medication is an alternative for vancomycin. So vancomycin is the first-line treatment. And we shouldn't use linezolid until there is a need or indication for linezolid. But it was used like a paracetamol. So after we control, you can see the difference. From 1,600. And there's another example, mirabinate. It was 6,000, and it is reduced to 5,000. Only within 1 year. Within 1 year. So after we calculate how much we save more than 70,000 riyal by controlling the prescribing of antibiotic. And we didn't affect the patient treatment. We didn't affect the patient treatment. But we were controlling the prescribing. Yes, controlling the prescribing. The same thing for the second line. Was the second and third line. And this is the first line treatment, the other treatment what we use in our hospital. So we were not only focusing on the expensive medication. We were controlling all the medications. So we're controlling and helping the others to prescribe correctly and rational prescribing of antibiotic. So this is, you can see in 2018, this is the red is 2018. After 2018, that's consumption decreased. Because in that area it was increasing dramatically, but after we start our stewardship, the consumptions and the rational was increasing, consumption was decreasing for the antibiotic use. Even here for the cheap medications, even the consumption was in 2018 was obvious, it is increasing, but then we could control the medication. So you can take, if you are stopping the third line or second line, it is good thing to increase the first line, because some people doesn't need the strong medication. You can treat them with even the weak medications or the antibiotic, but you need to rationalize the use. Not only use the strong medication or the expensive medication that's good for the patient. No, it's rationalize the use of medication for the patient. So this was our plan to make our biogram, then to analyze the cultures. That's what we did in 2018, 2015, 17. Then to have some information which can we start as a fundamental, and to analyze or evaluate our job after 5 years, which is 2022. So in 2022, we have another research to evaluate our job, what we did in the last 5 years. So the first thing what we did, and that result that we have analyzed more than 9,000 isolate, and 7,000 of them were from Sohar Hospital, because Sohar Hospital have some, the lab of Sohar Hospital check for Sohar and for North Batna. So the total of 9,500 approximate is not only from Sohar. From Sohar only 7,500. And that approximate 31 of them has resistant isolate. So the resistant isolate come from CRE 6%, ASBL 13%, MDRO 4%, and MRC it was 5%, and vancomycin VRE is 0.14%. Here it is clear for CRE. For pediatric is different from adult, that's sure. Pediatric is less than adult. So most of the culture came from adult. And here we divide the years into four areas. Every 4 months there is some isolate. We check them. Mostly they are the same trend, so there's no different trend between them during the years. And this is the number of the isolate and how it is divided between the adult and pediatrics. And this gives us a big idea. This is in 2018, our first research, and this is the second research. You can see for CRE, you can see here, CRE was 5.7, but now it is 6.8. Little bit increase in the CRE. But check C for ASBL. Now it is 13.7, it was 17.1. And even for MDRO, it was 11, now it is 5. So you cannot reach zero resistant. There is a resistant, but you should make some improvement. As Zainab said, the trend is different from hospital to another hospital, and from time to time. It is depend on your effort. So you cannot reach the zero resistant, but at least you make some improvement. So when we have some MDRO, 6% instead of 11%, it is 50% improve. It is good for us. And we can improve our job and see how can we improve that areas as well. And you can see here the consumptions. This is give us the consumptions. You can see for cholesterol, for example, as per the DDD, which is defined as which is international guideline metric unit used for check the antibiotic consumptions. So for cholesterol we have 0.55, but in 2022 it's 0.35. Big improvement. Even not only for cholesterol, for other antibiotics, for linezolid, it was 0.05, then we have 0.01. So we calculate the consumptions, we calculate the susceptibility and resistance for antibiotic. So that not only for one medication, even for mirabiram, it is 0.5, now it is 0.3. So for different medications, we have some improvement in the consumptions and susceptibility pattern. And for the pharmacist's responsibility, that's interventions. The main thing is intervention. As I said, the pharmacy is the fundamental person in the stewardship. It starts from the pharmacist. So this is the areas where the pharmacists have interventions. So the big intervention was the dose, interactions, frequency, duplicate, and indications. Yes, the doctor, he's treating the patient, but we have something to do and help the doctor to correctly or rationalize the use of antibiotic for the patients. The main problem with us was the duplications, because sometimes even in our different practice, they prescribe a medication which has duplicate to other. For example, augmentin or tazocine. It has some anaerobic coverage. So no need to give metronidazole with that patient. But most of the prescriptions, they prescribe both. They thought they want to cover anaerobic and other things. Yes, but this medication, for example, tazo, it's cover gram positive, gram negative, and anaerobic. So no need for metronidazole. So there are some areas, small area where the pharmacist can interfere and help the doctor to rationalize the use of antibiotics. Then we have our antibiotic standard of dilutions, because this one of the areas what we found it in our hospitals, that every department has different dilution for the medications, for antibiotics especially. When you ask them, how do you dilute, how do you prepare antibiotic? They said, we have this from our previous staff, senior staff. Do you have a reference? No reference. That's why we have started to look through all that preparations, and we start to look for a reference. So we have a standard with reference. This is our standard in our hospital. This booklet was distributed to every department in our hospital. So every department now prepare the antibiotic according to this standard, and was prepared by the pharmacist. Then, as I said, during the 5 years, the SBL was the predominant. As Dr. Zainab asked me, SBL is predominant not only in Sohar, in all Oman. As per the national statistic, SBL is the predominant and phenotypes in all Oman. The excessive use of antibiotic was in COVID, as I said, because that was a strong period for us and for all Oman. They don't know how to do with the patient, but at the end we could control some of that areas. And I think Sohar Hospital stewardship was successful. And yes, there is some improvement, but we need to work harder to improve our service as well. This is the areas, and economy for our teams and that thing. Thank you.
Shukran, Dr. Ahmed, and really appreciate actually the great job done by the pharmacy team there in Sohar Hospital. I have seen in one of your figures, like although you started implementing this stewardship program maybe in 2019 onwards, but in one of the figures, like the consumption or the prescription of antibiotics in 2018 compared to 2017 was peaking up. Is it because of, I don't know, the increase in the number of patients in that hospital, or was there an expansion, or because of the nature of diseases at that time? Maybe have you observed that, like 2017 to 18, there was a big jump? Yani?
Because the number not increasing, but see, the awareness is decreased because the doctors start to prescribe a lot of antibiotic for some patients. That's why the ideas came to how we have to start our stewardship, because there's some irrational use that was noticed by the intervention of the pharmacist, because they noticed there is something wrong. We should do something. But as a pharmacist, we cannot do it alone. So that's why we should have something like a stewardship, which include infectious disease doctors, pharmacists, and other people. Because dealing with doctor, I don't want to say it is difficult, but sometimes some doctors doesn't believe in somebody not in their field. So when they are discussed by a doctor, it's different from they are discussing with a pharmacist. Even if the pharmacist has a knowledge, they thought, no, doctor should speak to me. Even when we had ID doctor, the same thing. Some doctors, some specialty, they don't want that ID doctor to change their prescription, because they say, this is my patient. They say like, this is my patient. I'm treating the patient. It's not your patient. But he's the patient, not yours or mine. We should rationalize the use. That's why when we have a team, the practice was changed a little bit.
Thank you very much, Dr. Ahmed, for the insightful presentation, and appreciate the great job done in the hospital to reduce antibiotic resistance. But just one simple question. Did you take into consideration do you practice in Suhar Hospital the idea of automatic stop order by the clinical pharmacist? And do you have the right to stop the order if you feel?
It's not the pharmacist's right. We just, as we said, the stewardship is not the one who stop the medication. We just advisory committee. So when we have something wrong, as if you remember our from the beginning, you can say, we said we're discussing with the primary team. So we discuss the matter with primary team. If we convince them, here. First of all, the pharmacist can revise the prescriptions, discuss with the ID, then all together discuss with primary team. So the primary team only the one who has the right to change the medication. But we can convince them because we have some scientific answer for everything.
So just recommending.
Recommendation.
Up to them.
Yes. But mostly they are, in the beginning they were resist, but now they trust us. So sometimes they called us, sometimes they refer the patient to us because they said, we have this patient and this is the culture, what do you recommend for this patient? This came with time. Now we are more than 5 years and they are, knows our numbers. They're contacting us.
Thank you very much.
But there's no right for the pharmacist to change any medication. The pharmacist is advice only.
WHO, they have a list of essential medicines, and also they have separate booklet on antibiotics where they mention about that aware, right? So are you using also the guidelines which are under aware for antibiotics? Because recently they released new guidelines in September 2025. So are you also following that?
As per the last update from WHO, we merge it with our guideline. We check some medication, that guideline is not applicable with us. So we don't use it totally. Because if you have checked that guidelines, you can find some medication which is first line with us, they are second line with them. So it's not applicable with us. Even for some of them that what you is restricting over here, they are free to prescribe over there. So we take some of them, but we don't use it totally.
Okay.
Yes.
Because they have now listed under excess, watch, reserve. So you are not strictly following their guidelines. Okay.
Well, used partially, but not
partially.
100%.
Okay.
Yes.
Okay. Yes. So that means the reserve antibiotics under WHO essential list could be under watch for you, and some under watch could be excess for you.
Yes.
Okay. So you have the full freedom to change that.
Yes.
Okay. Thank you. Thank you so much.
Assalamu alaikum. Thank you very much, Dr. Ahmed, for the excellent presentation. My question is related to some events there was a meeting, global meeting organized by WHO in 2010, and they discussed about the antimicrobial resistance, mainly in Europe and USA. And the number that raised there, that more than 95% of the antibiotic that was in the market has resistance. That's in 2010. Even they are following strong stewardship and guideline. And I'm happy to see this improvement in the result related to decrease the resistance. But do you think there will be another factors rather than controlling the prescription? For example, as Dr. Zainab, she mentioned before, about the pollution that could be in water. Water resistance of bacteria could be found in the environment, even related to the prescription. It could be related to the waste management of the pharmaceuticals products, mainly antibiotics. Is there any concern for this to help to improve also to decrease the resistance? Thank you.
Thank you, Doctor. See, you should know that you are not alone in the global. So what's happening in Oman can affect what's happening in the US. So the people is moving around. And the main area of resistance of antibiotics is agriculture, not the medical areas. So the main areas where the misuse of antibiotic is agriculture. That's why you can, if you have, there's a report, if you check the report, they found that the most resistant of antibiotic came from agriculture. As Dr. Zainab said, they found some water harm, some colistin resistant, which is, colistin is working with us. It is strong medication and we reserve for medication, but with them, it's resistant because they use it in agriculture. How did it reach the water? Because they're using it in agriculture. That's why, even when we are starting in Oman,
There was on Saudi Arabia, one study they are found using colistin to feed the animals, the camels and so on. They don't want any infection to happen to them because you know the camels is very, very expensive. So from that, it is coming as well the resistance pattern because they are using only to save their life. So regarding just one comment regarding the WHO aware and watch and reserve. Definitely this is WHO guidelines. We already integrated on our Shifa system, and when doctors from ministry, when microbiology result is coming, it is mentioned. For example, ampicillin is access. No, ampicillin is access, and it is sensitive. So we are telling doctors, please use the access antibiotic when it is sensitive. This is the first thing. Second thing, when it is applicable, because some of the antibiotic, you cannot use it for certain bacteria. Because what? Because the locations. You want like it is not penetrating CNS or not penetrating bone. So you have to choose. But definitely some of them sensitive to the, and it is access, but we are using the watch. Because of this indication.
Very good. That's exactly what I was asking.
Yes.
See, what Dr. Zainab said, see, we are treating a patient, not treating a culture. Because some doctors, when patient came, they make different culture for the patient. For example, patient came with fever. So we'll make culture, blood culture, urine culture, sputum culture. Then they try to choose which culture is positive and give the patient. It's not a rational way. It's not a rational way. Yeah, as Dr. Zainab said, it is in the system, but in our system, if for example, meropenem is watch, we will not prescribe until our IDA approved. Yes.
Yeah. Because the meropenem, it is the bigger. Yeah, we have restrict meropenem, tazocine, vancomycin, linezolid, tigacycline. And all pharmacies, they have to review this prescription and later on to discuss with microbiology ID doctors to get the final result, final decision, then to talk to the doctors. And on our hospital, right now, we start something aggressive, which we are stopping antibiotic. Microbiologists, they are stopping antibiotic when it is not necessarily. And they are documented, and this was a good step from our stewardship, and also it is supported by the director, hospital director, and already there is a guideline. They send it to doctors to follow this one, especially the antibiotic prophylactic, because they are giving cefazolin for 5-7 days discharge on antibiotic, which is no need. Only 24 hours to give the antibiotic, then stop. If they didn't stop it, we will stop. Khalas, this is the final decision we are going now on this stage. We already discussed, we already passed this discussion We already discuss, we already review, يعني talk to them, convince them, nothing happened. Now is time of action. To be honest, this is time of action. So far, only we start like end of October. Yeah, and it is only 1 month maybe. So we had and when fight. Okay, maybe this Thursday we'll have a discussion about this fight. So inshallah we'll be raising this.
I would just like to share because there was a pharmaceutical company which was preparing a formulation and they were adding antibiotic resistance breaker in that. So they are also making new formulations to combat these problems, you know. So I don't remember exactly what it was, but I think it was some streptokinase or something they had added, and they mentioned it as part of their marketing strategy, that we are adding it as an antibiotic resistance breaker. So something or the other is definitely coming up, you know. Yeah.
Thank you.
Assalamu alaikum. Dr. Ahmed, thank you so much for the wonderful talk. It is good to see that you saved a lot of money for the Sohar Hospital and for the Ministry of Health. I was just like curious to know, you showed around 70,000 riyal you saved in a year, right? But if you are saving on one, don't you think you are increasing on the other side? So how much is the net profit? I would like to see that. Because of course, you are decreasing the use of meropenem, clostridine, and linezolid. So, but the use of primary first-line drug will go up. So how much was the net saving? Thank you.
You can see over here.
Yes.
See, it is 70 was saved, 70,000. Yeah. And the other way, the other antibiotic was increasing. For example, those antibiotics. You can see it is minus over here.
Yeah. Yeah. But how much is the total saving? I mean, like, how much do you save?
Total,
71. That's what I'm
the numbers. But
yes.
You can calculate it from here.
Yeah.
So we can save from here. It is more than this is as well.
So 2,500 around. You saved. I mean, you spent extra.
Yes.
Yeah.
This is the money.
They spend.
Yes.
Yeah. Okay. Yes. Because if you increase in one,
overall, you restrict somewhere, some other way will be increasing. That's why.
The number of patients remain the same, but the drug category you are choosing, you are basically cutting down the cost.
This is the extra amount. See, it is here.
Yeah. 5,900. Yeah. Thank you.
6,000. Yes. We save 70,000, and there's 5,000, 6,000. It's not that much. So 70,000 is bigger. So no need to see to this 5,000.
So you are also doing pharmacoeconomic studies along with that?
Yes. Not pharmacoeconomic, but just calculation for the consumptions. Yes, yes. Yes. Because for stewardship, you need to check the susceptibility, resistant, even the consumptions. That's why we are using all of these. Yes. It can be calculated as well. Yes. There's a different area, different metric strategy for the stewardship. So we cannot use all of them, but we use some of them which can show us where our situation is. What should we do more to improve our practice? Yes.
And you have rightly pointed out, like in the past 50 years, we have not have a new medication, new antibiotic. What could be the reason? Resistance is increasing, but we are not getting the new drugs. What could be the cause?
See, there's no new medications. There's little new medications, but mostly they convert to the combinations. So most doctors now use combinations. Even for example, ceftazidime. We have ceftazidime, avibactam.
Exactly.
Have, there is some combination which can reduce the resistance, as Dr. Alka said, because some medication now can be combined with other components which to reduce the resistance.
Yeah, but this is not the practice in Oman. Usually we don't say the antibiotic combination, except few, like alliance drugs. In other countries...
Actually we have it. We have most of them.
Okay. Many combinations are not marketed here, actually.
See, I'll tell you something. Different countries, different practice. Okay? In Oman, we have every medication is separate. But for the combination like ceftazine ifibactam, it is available. For example, augmentin is amoxicillin and clavulanic acid. It's combination. And there's another medication coming, which is asturinum with avibactam is coming on. But for other medications, we don't like the combination. I know in India, even for the anti-diabetic, there are combinations. For antihypertensive, there are combinations, and the other thing. I know it is convenient for the patients, but we don't have it. Yes. And last thing I want to say, see, the hospital is area of data. So if anybody is interested in study or research, come to hospital. It's a rich area of data. And it is virgin area. So come, collect data, start research. Thank you.
Thank you, Pharmacist Ahmed, for the wonderful talk. I would like to now invite Dr. Sumaya Al-Kindi, a research and studies specialist, to deliver the vote of thanks.
Assalamu alaikum wa rahmatullahi wa barakatuh. Dear guest, respected speaker, colleagues, and dear students, as we came to the end of this opening ceremony of our research symposium, it's truly an honor to deliver the vote of thanks on behalf of the College of Pharmacy. I would like to express my sincere thanks to Prof. Khalid Al-Balushi, Dean of College of Pharmacy, for his welcome of his constant support of all academic and research efforts. Your guidance always inspire us. My thanks also go to Prof. Ramchandran, Dean of Deanship of Graduate Studies and Research, for joining us and sharing magnificent and encouraging words that motivate us to work harder and aim higher. A special note of thanks to Prof. Alka Ahuja for her clear and insightful overview of research activities at the College of Pharmacy for 2024-25. Your dedication to strengthen the research at the college is truly valued. Thank you. We are deeply grateful to our distinguished speaker, Dr. Lamia Ahmed Ashuhaimi, pharmacist Zainab Saeed Al-Hashmi, and pharmacist Ahmed Talib Al-Zaabi. Your talks were informative, rich, and inspiring. You have added a great depth of today's events. I would like also to thank each member of organizing committee, our faculty, staff, and all who worked quietly behind the scenes. Your hard work, cooperation, and commitment made this symposium possible. Our sincere appreciation also goes to the student volunteers, media club, everyone involved in arrangement, refreshment, flowers, photography, coordination, booklet proceeding. All your efforts may not be always seen, but it is always felt. As finally, to our students, thank you for your attendance and your energy and enthusiasm. You look forward, inshallah, your presentation this afternoon and to see the bright ideas, inshallah, and will build to the future of the research. To everyone here today, thank you for your presence and your support and your contribution and to make this event success. I wish all the productive and inspiring continuation of the symposium. Thank you so much.
Thank you, Dr. Sumaya. Now to all the guests, please scan this QR code to get your e-certificate. It's going to show in a bit. We will now take a 1-hour break before the next session. I kindly request everyone to return at 1 p.m. for the oral presentations by the students. Thank you all.